Step therapy is where a doctor will prescribe the least toxic drug or the simplest approach and then move on to more aggressive treatment as needed by the patient, and that's good practice. However, what has been happening is not all patients need to start at step 1. They need step 4 right away because of the seriousness of their illness. And step therapy, where it becomes a problem, is when the insurance company overrides what the doctor thinks and says you must start at step 1. You must take this one first and then try this one and then try this one. In the meantime, that becomes a real patient safety issue because if, let's say they have organ involvement like the kidney, you can't wait for 6 months to get to step 4, which your physician who's trained and has the knowledge of you as a patient wants you to take the very first step, is step 4.
One of the challenges of step therapy, and in many cases in rheumatology, this applies to patients with rheumatoid arthritis, which is one of our more common diseases that we see. And it seems to be that insurance companies have made their decisions of which drugs they're going to help cover for the patients, and that doesn't always match what's the safest or the best for the patient's care. So they may tell us you need to try a drug, for example, adalimumab first, and you cannot prescribe abatacept first because we're not going to cover abatacept. On the other hand, there is research, for example, from 2013 that has been published in medical journals that says that the abatacept came out safer in terms of infections and other serious adverse events than the adalimumab. And in a patient that I might have that's had a history of repeated pneumonias or problems in the past, I might put a lot of weight on the fact that there were less infections with a certain drug than the other. However, since these drugs are $5,000 per month approximately, if the insurance companies say, we won't cover abatacept until you have tried the other drug first, we're pretty much forced to try the other drug first, even though clinically we don't feel that's the best option for the patient's safety and care.
I think Dr. Kasmer's made a very good point and really explained a lot of what we're dealing with nowadays with step therapy. I'll add to that pharmacy benefit managers are the ones that are determining what drugs are on formularies. And it's all an economic thing. It's all based on the cost of the drug. It's really not based on the benefit of the patient. We have insurance companies trying to practice cookbook medicine, and they have their list, and you're talking to people on the phone trying to get prior authorizations who aren't even physicians. They're looking at their list, and if you don't fit their exact criteria, they're denying you. And some of these criteria are harmful. Dr. Kasmer's mentioned a couple instances where there's a drug that's safer than another one. I have a good example of a patient whose sister had multiple sclerosis, and we know that some of the drugs, like the TNF drugs, increase the risk of multiple sclerosis in patients that have family members with it, yet the insurance company denied it because the TNF drugs were first line in their step therapy. And nothing I said on the phone would convince them that this patient could not be treated with one of those TNF drugs. Why? Because they say it doesn't say that in the package insert. True, but if you look at all the literature, you don't want to treat somebody who has a family member with MS with a drug that could potentially cause MS. So I think in regards to step therapy, there's a lot of problems as to who's making the decision to what drugs we can use. It's not based on what's best for the patient because every patient's different. Patients aren't the same, and what works in one person is not appropriate for another. As Virginia said, there's patients that have kidney problems, and they want us to use drugs that maybe can't be used in somebody with kidney problems, or somebody has more severe disease and you want to be more aggressive with their therapy from the beginning. In the American College of Rheumatology, clinical studies show that if we start patients aggressively with treatment right off the bat, these patients do better, yet because of these pharmacy benefit managers, we're not allowed to treat patients the way we know they should be treated.
We want to think based on our experience in our studies, what is the best drug for this patient given the scenario that they're in at the time? And we will make this clear to the patient and give them the reasons. Then we go ahead and prescribe it and find out that the insurance company has decided, no, we will not pay for that because we want you to use this one, whether that's because of some kind of financial deal that has been cut with the other drugs company or what have you. I've been informed that that might be one of the motivations for this problem. We have to go back to the patient and call them and say, hey, we wanted you to start drug X right away for your benefit, but we can't. If we try to get it, it's going to be an appeal, or maybe sometimes 2 or 3 or 4 appeals, which may delay the treatment for a matter of weeks or even sometimes months, unfortunately. And this, I think, is not a unique experience for me. I've seen that with other doctors complaining of this. Meanwhile, the patient is suffering and in some cases could be incurring permanent joint or organ damage while this process is happening. And we are fighting to get them the drug that we think is the safest or the best.
I have a young man, he's 23 years old, who has familial Mediterranean fever. He's been on Colchris, which is one of the formulations of colchicine, doing well for many years, and his insurance company now denied Colchris, and he went on Mitigar, which is another brand for this drug, and within a month on the Mitigar, he had a flare he hadn't had in years. Colchicine, or Colchris, is approved for familial Mediterranean fever. Mitigar, even though it's colchicine, is not approved, yet his insurance company is denying him to be treated with this drug. It's the same basic compound, but it's a different formulation, and the family at this time is paying for the drug because it's not a biologic, it's not thousands of dollars, but it is quite expensive, and they're paying out of pocket because they know that he cannot tolerate this drug. And that's affecting patient care directly. It happens with more expensive drugs also, where patients don't have the liberty of buying the drug themselves.
Right. And I asked my nurse, who helps with these appeals and so on, to give me a few examples to bring to the table. One example was a patient who had been doing well for a number of years on one of our drugs. I'm going to go ahead and use a brand name, Orencia. And this had controlled the arthritis, meaning the pain and suffering, as well as reducing the likelihood of deformities and disability. However, the drug company decided, or it may have been a case where she had changed drug companies, decided, no, we're not going to cover that. Even though you've been doing very well on this drug, in other words, for 5 or 10 years, we don't have that as our option or our best approved drug for your disease. You're going to have to go to some other drug, and they'll give us a couple of choices, none of which I really want to prescribe because, as Dr. Santos knows, as a rheumatologist, when we find a drug that fits the patient like a glove and they're doing fantastic on it, we don't want to rock the boat because the next 1 or 2 or 3 or 4 that we try may fail miserably. It depends on the person's body chemistry. So if we hit a home run and we find one that the patient is doing very well and we know that their risk of joint damage has been reduced, why do we want to take the risk of switching to something that may fail miserably? However, they insisted on us trying a different drug, and we are trying to appeal that, which could take my staff hours.
And that's a very good point, because I've seen that many times where patients have been on a drug for many years, they switch insurances, and all of a sudden it's not their step therapy. And you can't follow the step therapy of every insurance company because they're all different. And now this patient is going to suffer because, as you said, we have to take them off that drug, which I refuse to do, and we have to fight and try to get the insurance companies to cover. But now we have to tell the patient you're not being covered when they've been on the drug for 10, even 15 years, doing very well.
I'd like to jump in here on the behalf of patients. Patients find this very frustrating because they have selected a doctor, a specialist, somebody they know that treats and has the medical education to treat their very serious disease. And someone else, without any training, is interfering with that decision. And I guess that kind of brings me to a pet peeve of mine. What I see happening in our healthcare system is the erosion of the doctor-patient relationship. And that is a very important relationship of trust. You have to trust that that doctor is treating you the way you expect you're getting the best treatment from that doctor. And then you find out that a benefit manager is making that decision. That benefit manager does not have the training, does not have the 12 years of experience, is not specialized, and most of all, doesn't know that patient. In the case of autoimmune diseases, patients are very different, as you two know, when you treat them. And how they react to medications and what works for them can be different with each patient. Or the susceptibility to infection might be very different. So you're going to force that patient to take something that then they develop an infection, then they are in the hospital with an infection.
Well, the step therapy, nobody's proven to me that this is based on what's best for the patient. It's all economical. The pharmacy benefit managers call them rebates, what the pharmaceutical companies give them to put their drug on formulary, but it's all based on who gives the biggest rebate, and you could probably call that a kickback, I think. But anyways, it's something that should not be involved in determining what drugs are approved for what patients, but unfortunately that's a major player.
And even then, the patient does not get the benefit of that cost reduction.
Correct.
The benefit manager gets that
That's correct.
money.